Okay, we are now recording. So welcome everybody. Good afternoon. Welcome to our roundtable meeting, the JBBS Roundtable meeting. Just in case you were unaware what meeting you were joining, that was a joke. So I guess a couple giggles. But so we are going to get started super fast because we've got a lot. Thanks, John. We've got a lot to discuss today. We have Hannah Hall here with healthcare policy and financing to talk about the 1115 waiver. But before we do that, I'll do quick introductions for BHA staff because it looks like there's only a couple of us right now. As everybody probably knows, but in case you don't, I am Becky Huckabee. Please ignore my Rebecca because I can't stand being called Rebecca. So if you could please call me Becky, that would be fantastic. I'm Becky. I am one of the JBBS program managers for BHA. And unfortunately, Kelly couldn't be here today, but Kelly says hi for everybody. So I'll pass it on to Alex.
Hello, I'm Alex Clayton. I am the program coordinator for data. So I'm the monitoring and evaluation program coordinator for all criminal justice programs here at the BHA. And yeah, most of you know me by now, but just wanted to reintroduce myself. Who else is on the call from BHA?
I'm thinking that might be it. Anybody else? Do we have Danielle yet? Danielle said she'd be a little bit late, but I think it's just us. So you all get to deal with me and Alex today. So that's fun for you guys. All right. And whoever couldn't be here today, if anybody from your agency couldn't be here but would like this information, I have definitely been pushing, Hannah. I've definitely been pushing at folks coming to this presentation. This is specifically the roundtable meeting is specifically for jail folks. So this is not generally open to providers for this particular meeting. But if you do have a provider that would like this information, I will be posting this call to the JBBS website as soon as it's downloaded and as fast as my comms folks can post it. So if other folks would like to review this information, this will be posted hopefully within, I'm going to say probably by Monday or Tuesday because I'm out on Fridays. But with that, I'm going to admit this person. All right, with that, I'm going to pass it on to Hannah. Hannah, I'm going to let you do your own introductions. I also made you a co-host, so you should be able to share anything you need to share, do whatever you need to do.
Awesome. Thank you so much, Becky. It's nice to see all of your boxes. I think that I see a lot of familiar names on this call. For anybody who doesn't know, I am the Criminal Justice Policy Advisor over at the Department of Healthcare Policy and Financing. And my main task is working on implementation of our 1115 waiver reentry services. So I'm going to be talking to you all about the 1115 reentry waiver today. And then towards the end of the call, I'm going to hand it over to one of my coworkers from the department who's going to share about a different project, the Social Health Information Exchange. I'm going to share my screen with some slides. While I'm getting that set up, just for anybody who has questions, please feel free to jump in, interrupt me, just hop off mute and ask questions throughout the presentation. Hopefully I have some helpful information for you today, but I'm happy for this to be a discussion as well, and for you to ask whatever questions that you have. Our agenda for the day, I'm going to start with some general information about Colorado's 1115 waiver and MREACH. This will be a refresher for folks who have heard me talk about the 1115 waiver before. And then for items 2 through 4, that'll be some more new information where I'm going to provide some more detail on the timeline from jails, what you can expect kind of the next year to look like as we're working towards our goal implementation date of July of next year, and getting some next steps lined up. So overview on the 1115 waiver as a whole, just some really kind of background information on why we have the 1115 demonstration in the first place. It's important to recognize that Medicaid, being both a state and federal partnership, means that the federal government can set rules, minimum standards, requirements for the Medicaid and CHIP program. And the 1115 demonstration is an opportunity for states to waive some of those federal rules, to have more flexibility, to do pilot programs where we explore expanding different sets of folks or different services, and can demonstrate their effectiveness. This type of waiver is a 5-year agreement, and Colorado's current waiver for the last about 5 years has been a substance use disorder waiver, and that is what has allowed us to offer certain substance use disorder services as part of our Medicaid program. And this same authority, the 1115 waiver, is what is allowing us to offer reentry services. As folks who work in the jail are probably very aware, Medicaid has an exclusion, a payment exclusion for folks who are considered inmates of a public institution. That phrase is federal language. That's how they determine who we can and can't pay for services for when it comes to incarceration. And so that federal statute that prohibits us from paying for services while someone is incarcerated, that is the statute that we are able to waive through the 1115 demonstration waiver. We had previously applied in April of last year for our 1115 waiver amendment to offer reentry services. The waiver amendment was approved in January. And now Colorado is going through our regular 1115 waiver renewal. So that's what this slide is going over. And as a note, some of these slides are dense, but I wanted you all to have this information. But we'll be able to share these slides out after the meeting so that you'll have these to refer back to if you wish. But we are requesting, if you're seeing information like this, note that we're requesting no changes to our 1115 waiver in our renewal, because the extra services and the extra programs that we were adding on, such as reentry, had already been approved during what was the tail end of technically the last 5-year period that we had for our 1115 waiver. One thing that I want to call out is that in our waiver renewal, we were requesting to continue the substance use disorder services, as well as to continue this kind of last 5 bullets here were newer things that we added on to the 1115 waiver just before this renewal period. One thing that I have gotten some recent questions on is continuous eligibility. If you're on some of our mailing lists, you may have gotten a notice that the federal government is not expecting to allow continuous eligibility through 1115 waivers. And so we're not expecting the continuous eligibility portion to move forward. Where that intersects with reentry is that they were going to be able to serve similar populations. Continuous eligibility was going to be available for folks releasing from the Department of Corrections to provide continuous eligibility. So if you're seeing that that is no longer available, I just want to clarify that that was a distinct effort that we were pursuing from the criminal justice reentry services. So we're moving forward with the reentry services. But if you hear that continuous eligibility is not continuing for folks, or that we're not going to be able to start that for folks releasing from prison, that is what they're talking about. And just want to distinguish that from reentry so that it's clear that reentry is still continuing for that population, just not the continuous eligibility. Now for the 1115, or for the reentry component of the 1115 waiver, this is kind of all of the same information that we've had since we originally applied for this in April. We are seeking to cover all Medicaid and CHIP eligible individuals. So anybody who is incarcerated and is a Medicaid or CHIP member is going to be eligible for reentry services. There are not additional eligibility criteria beyond that. For the eligible settings, most all correctional settings, aside from federal prisons, from federal facilities, are going to be eligible settings for reentry services, and we're phasing in the rollout of that. We are starting right now with state-run facilities, which for us is our Department of Corrections and our Division of Youth Services. If you've been listening to me for a while, you know that we were originally aiming for July of 2025 to begin in state facilities. We have not yet fully implemented in state facilities. We still have a few pieces of outstanding federal authority before we're able to go live. So state facilities are going to hopefully go live later this year in 2025 when we get that outstanding federal approval from CMS. But we're still working towards the same date of July 2026 for jails as being the earliest date that we can pay for services, and hoping that we're able to wrap up all the outstanding pieces of federal authority before then. The eligible time frame for the services that we're going to be able to pay for is 90 days prior to release from incarceration. So for lots of folks in a jail setting, that would be their entire stay. And the services that we have authority to cover are medication-assisted treatment in the 90 days prior to release, targeted case management in the 90 days prior to release, and then a 30-day supply of all prescription medications upon release. Any questions so far?
I have a question.
Yeah, go ahead.
Hi, April Lund, Garfield County Sheriff's Office. Our agency has gone back and forth with our understanding of what it means to say the 90 days prior to release.
Mm-hmm.
As a county jail, we frequently don't know when a person will be released. They could book in and book out in a couple of days. That's really up to the courts and what happens in their hearings. So the minute that they book in, would that start their 90 days prior to release, or is there specific language surrounding that would help us understand that better?
Yeah, so we'll have billing guidance that will provide like all this minutia and the detail of how jails should consider that. What we have worked out for the state-run facilities that I expect will continue for jails as well is that we are going to do retroactive billing. And so you would just wait until an individual releases and then bill for the 90 days prior to that date so that you know exactly what that 90-day period was. For a lot of folks, I think part of this will be jails using discretion and their best judgment. For a lot of folks who are not going to be there very long, that's when you would expect that you're going to be providing the services and you're going to back bill for however many days up to 90 days they were there. If you have somebody come in on some really serious charges and you don't expect them to get out for a year, then proceed how you would. But that is how we're dealing with the 90-day release window, because we recognize that even on the DOC side, where it's a little bit more predictable, you don't always know the exact day that somebody's going to get out. And so our solution to that has just been to have the billing occur after release. And then the one thing, which is probably more specifics than you need right now, the one thing to consider is timely filing. But for Medicaid, medical services, timely filing is like 365 days. And so if you're getting we don't expect it to take that long, of course. And so you have a pretty good buffer there to stay within the scope of timely filing while still waiting to bill until after somebody leaves.
Excellent. That's really helpful. Thank you for that.
Yeah. So yeah, nobody can guess these things. Yeah, go ahead.
Yeah, hi. Actually, April, thank you for asking that question because we had the same thought. But I wanted to ask about the 30-day supply of prescription medications upon release. Are we just talking about MAT medications here, or are we talking about any medications?
That's a great question. So the 30-day supply of medications upon release is any medications, as long as it is a medication that is covered by Medicaid that aligns with our formulary. So the piece that's MAT specific is what's available 90 days prior to release. So in that window 90 days prior while someone is still incarcerated, the only medication that we can pay for is MAT medication. But then when you're talking about that 30-day supply upon release, it's all covered medications.
Okay, thank you.
So this is the timeline that I have been discussing with you all. Like I've said, we applied for the reentry component of our waiver in April. We got approval in January to add that amendment to our 11.15 waiver. But now we just have some additional outstanding federal approvals that traditionally come after the waiver amendment is approved. That is, like I said, having more of an impact to the timeline for state-run facilities, but still aiming for July of 2026 for the local facilities, which would be jails and tribal detention centers. And then the little box that I have down there in gray references the facility readiness assessment. I have another slide on this and a couple slides that gets a lot more specific, but I wanted to add that component to this timeline that talks about the authority, because Medicaid's ability to pay for reentry services provided to a member in any specific jail is dependent on two things primarily, which is having all of our federal authority. And then the other thing is that having that facility pass their readiness assessment. And so I want to make sure that jails are all aware of that even when we have authority as a state to begin paying for services, the thing that each individual jail will have to have in place before we can pay for services in that specific facility will be their readiness assessment. Right. Now getting more into the weeds on what the jail engagement timeline is going to look like. We are hoping to have some more news for you soon this month on the reentry state planning grant that we applied for. That is something that the jails had provided feedback on in relation to our application priorities for that. So hoping to have some more information to share with you all soon. And then over the next few months between now and October, we are going to begin engaging more earnestly with jails and focusing on gathering information. What we want to understand from our side is have more information on the current status of the covered services in jail settings. And so what examples of what my team will be looking to understand is whether of those 3 services we just talked about that Medicaid will be able to pay for, whether they're currently available in your jail. If they are available in your jail, how are they funded and who is providing them and where is that information trapped? Kind of like what EHR are you using? Is the provider a vendor or is it facility staff? Like really getting into the nitty-gritty of what those services look like, recognizing that it is going to be different. It's going to vary across facilities and making sure we understand for each of the facilities that wants to participate in Medicaid reentry services, gathering all of that information about the current status. The first thing that we are going to do is look to our state partners like the wonderful JBBS team who may already have some of this information. If jails have already shared some of this information with our state partners, we don't want to make you repeat that. And so that's going to be our first step. And so if it is a little bit later into this August to October period when you start hearing from me, know that that's what's happening, is we're gathering as much information as we can from existing sources, and then we'll come back to the jails directly for information that we weren't able to find elsewhere. And when we have that understanding of the current status of services in all of the jails, we will look to begin work sessions later, aiming for November of this year, so that we can begin working with you directly on the nitty-gritty of becoming ready for reentry services, talking about things such as what exactly does billing look like and who does it and what information do they need and at what point in time does it take place in retroactive billing and all of those things. We developed this plan based off of the feedback that we received last time, and a majority of the jails requested to have a new meeting series specific to reentry services so that we can more frequently and regularly dig into that. And so that is that series that is going to be starting in November. We're also planning to, through the information gathering stage, identify different cohorts so that there could be cohorts of jails who are getting ready together and be in the work sessions with the first cohort of jails, and then continue to report out likely on a quarterly basis to everybody about updates, progress, what we've achieved, what's coming up, things like that. And so in those work sessions, we'll probably be focusing on the topics that will be included in the facility readiness assessment so that we are supporting jails with their ability to pass that facility readiness assessment, recognizing that that's kind of our North Star of where a facility needs to be at. They need to have passed that assessment before they can start billing Medicaid for services. And then, as we saw on the last timeline, once again, July 1, 2026 is the earliest go live date that we have, because that is the date that we anticipate we will have the federal authority to pay for reentry services in the jail settings. Any questions on the timeline? Okay. Now, more about this readiness assessment that I keep referencing. The readiness assessment, we do have one that we have drafted for state-run facilities. It is still in draft form since we have those kind of two components of outstanding federal authority that we're waiting on. We're waiting for that to come through to make sure there aren't any changes that will need to be reflected in the assessment. But at a high level, the topics that are going to be addressed through the assessment are Medicaid enrollment processes, provider enrollment and billing, some specifics about the services delivered in the 90-day window prior to release, those 3 services that are covered, and then oversight and project management. And each of these categories in the assessment will have specific questions for the jails to respond to and really walk you through everything that you need to have in place in order to go live with reentry services. The assessment we do plan to revise for jails, and so there will be some changes for jails. I don't think they're going to be huge foundational changes. All of the things I just mentioned will still be in there, but there will be a few additions. One in particular, as an example, is that House Bill 24-1045, that is the state legislation that authorized us to pursue the federal authority to pay for reentry services through Medicaid. That same legislation also requires that jails who want to participate in Medicaid reentry services demonstrate a commitment to diversion or deflection. So that is an example of a requirement that is unique to jails because of the way that the legislation was written. And so that'll probably be something that we include in the jail version of the readiness assessment, where there's a place for jails to demonstrate that commitment, and then we can make sure that we're meeting all the requirements of our statute. Wanted to give that example, but I'll pop back to the readiness assessment. Any questions so far about this? All right, you all will hear much more about the readiness assessment. Since we have one drafted and have a good idea of what it's going to look like, I do anticipate that this will be just a really helpful tool to guide our efforts in those work sessions that we're hoping to begin in November, so that you know what it is we're working towards and kind of what those minimum standards are that we're all going to have to meet. All right. So along with the consideration for jail that I just mentioned, that there is the great question, April. I will check with my team to see what we're able to share so far. And so there is that piece of 1045 that requires jails to demonstrate commitment to diversion or deflection. So that's something for jails to be aware of. Recognizing that your participation in this program, I understand that Medicaid can participating, billing for Medicaid coming into this can feel overwhelming. It can feel like there are a lot of requirements. It's definitely different from some of the other funding that you all have had access to in the past, but it is a really great opportunity to have a long-term funding solution to support compliance with offering MAT services. And then just recognizing that we do acknowledge there are going to be additional administrative actions that are required in order to bill for services, probably beyond what you all are currently doing.
Hannah, you have a question in the chat from Rachel. Do jails need to reach out to you for consideration?
Rachel, when you say reach out to me for consideration, do you mean for like in order to participate or?
Yes, for participation.
Yeah, I am our main point of contact. I will share, there's an email on the last side of this presentation, but that is a email inbox. That's a really great place to reach out to. In addition, I have, and I think this is linked on the last slide as well. I've shared a Google form before for jails to just identify their desired main point of contact for me whenever I'm reaching out about Medicaid reentry services. And so I will, when I get to the last slide, I'll make sure that that link is there and that you have that as well. If your jail has filled out that contact form, then you should get all the information from me when I reach out about information gathering and when I reach out about setting up work sessions. So not as much that you need to throw your name in the hat for consideration, but I just need to make sure I've got your contact information and then you'll be getting things from me.
Okay, and is that form that we filled out towards the beginning of the year?
Mm-hmm. Yeah.
Okay, perfect. Thanks.
Mm-hmm. Chris, for definitions on diversion and deflection, I think that's something that we're going to need to dive deeper into. That language comes specifically from statute. And so I'm going to need to confer with some others on how that ends up getting defined, because that language is not from HCBF or from Medicaid. It's just language from that House bill that allows us to offer these services. So, but that's a good call out. Probably a good place for me to connect with the BHA team, as you all probably have a lot more experience on defining those two things. All right, now this may be an opportunity for some more conversation. One other thing that is called out in House Bill 24-1045 is that bill currently has language that states that Medicaid may only reimburse OTPs for the MAT services provided in jails. This stood out to my team because we were recognizing that this doesn't seem to align with the types of providers currently providing MAT services in jails. And there is going to be a bill draft coming from the BHDC JJS task force to be considered in this upcoming legislative session to expand this reimbursement for any providers who are otherwise licensed to prescribe, dispense, compound, or administer MAT. Any questions or reactions, thoughts about the MAT reimbursement? We're a quiet group today. You should be harder on me. April, go ahead.
Of course, I have questions. Sorry. I'm the one who makes meetings go long. That's my fault. When it comes to the 11.15 waiver, we hear a lot of information, but sometimes it doesn't come down into digestible chunks as to understanding how that's all going to shake out in the end. And you may not even have the answers on that yet, because I know that we're early into this, but like as an example, what does that look like in my jail? We have an ADP of 70 roughly. We have a Brixadi as one of our leading MAT medications, which is a long-acting injectable, and it's very expensive. We spent about $157,000 on it last year just for that med alone. What sort of dent does this make in it, or is that even a covered medication under Medicaid?
So when you're talking about MAT medications prescribed during somebody's stay, who is providing that medication?
That would be our medical subcontractor, our provider.
Okay. And I'm assuming they're not an OTP.
They're not.
So what we are concerned with is that the language that's currently in 1045 is really restrictive about who we are able to reimburse for MAT, saying that it would have to be an OTP. And so that is what would hopefully be addressed by this draft language coming from the BHDC JJS task force in order to expand that reimbursement so that your medical subcontractor, who I'm assuming is appropriately licensed to provide the medical care that they're providing,
yes,
would be reimbursable by Medicaid. And so that's that barrier that we're seeing in the way that the statute is currently written, that hopefully will be addressed before jails go live, just so that any providers who are typically able to provide that service are also able to provide that service in a jail setting, so that it's not more restricted just because it is a jail setting.
Okay. Thank you for that.
Yeah. You know, 2:36. We got through this a lot faster than I expected to. So on this last slide, I have a link to 1045, since there were those two specific pieces of that bill that I called out. If anybody curious to go take a look. This is the sign up for our criminal justice updates. This is a sign up list. I only use it when I've got a good update to share, so you won't be bombarded. But there will be, for example, this list will be included when we have an update to share about the reentry state planning grant. So that's a good email list to be on if you want to stay up to date. And then this is the form that I mentioned earlier for jails to identify their preferred point of contact for me to reach out to when I'm specifically engaging with interested jails on reentry services. I will use all of the other methods that I have at my disposal as well. I'll send things out through the JBBS team and through the criminal justice contact list. But if you want to make sure that the right folks at your jail are getting the information that they need, please consider filling out that form. And then I also post updates on our Health First Colorado and criminal justice involved populations webpage. So that's a good place to go for information. For example, we posted some resources about the CAA after the last time I was here with JBBS, and there were some questions about that. We added information to that webpage. So that's a good place to go for information. I update that webpage when I have frequently asked questions or other things that come up often, and add information there for folks. And then this is that shared email inbox that is a good place to reach out if you have any questions. or want to connect about anything. All right, I'm going to stop sharing my screen because that's the end of my slides. Before I hand it off to the other team at HICPUC who's here, are there other questions, things people want to talk about? I want to make sure that, you know, if I haven't addressed some of your burning questions, that we have time to talk about those things. I'm reading the chat. Yeah, Ronaldo, that's a really good question. We're going to need to work together in those work sessions to decide what that billing infrastructure is going to look like for jail facilities. We have part of the reentry state planning grant. One of the work streams, the number one work stream that we have in that grant, was dedicated to looking at billing infrastructure, recognizing that when it comes to taking this program off the ground, that's the number one thing that has to exist is billing infrastructure for the facilities that want to participate. And so hoping to have more to share on that grant soon, but we are looking at having some external support to help us identify what it can look like for jails to set up a system that makes sense. And then those are some of the things that we're going to be asking about when we are gathering information. And this is my apology and my plea that some of these questions are going to be really specific when we start reaching out to you about what your services look like. And we're going to be asking who provides the service and how is it funded, and whether it's telehealth or whether it's in person, and is it the vendor. And when we're asking all of those questions to try to drill down to like, what is the current flow of money and who is providing those services, that's what we're thinking about, is having that information to help us identify what that billing procedure is going to look like, and like who is actually the entity that bills. Maybe a jail bills, maybe it is the vendor themselves that does the billing because they're the ones providing the services. None of this is set in stone. None of this has been determined for jails, but just to let you into a little bit of the thought process of why we're doing so many months of information gathering before we get into those work sessions, is we want to have all of that background information because we know that we don't have the infrastructure for that right now, and we need to set up something that makes sense. Does that answer your question at all?
It does. Thank you. I know it's not a simple answer. I know even currently with trying to track JBBS patients when they're being released and things of that nature can be, because we're two entities that don't exactly communicate linearly with information, there can be those barriers. So that's why I was wondering if there was a solution there. Sounds like a perfect opportunity for us to create an EMR that submits the billing when somebody's released within the last 90 days. So if anybody's good with technology, let's hop on board maybe. Yeah. But just a thought. But thank you.
Yeah.
Love it, Ray. Love it.
Any other questions? I do want to recognize that, you know, because we're just starting on this phase 2 of reentry services, things like billing processes haven't been determined. But hopefully you understand with me that that is because we want to develop those processes together and make sure that they work. And so we will be working with you all to figure out what this is going to look like.
I was just going to add real quick too, please keep in mind that Hannah and her team and our team meet frequently, and we talk all the time. I was just messaging Hannah last night. So if you all need anything, if you have any questions, obviously, please feel free to reach out to Hannah. Feel free to CC us as well. I always, if I don't know the answer to something, I want to know the answer to something. So if I'm included on the answer with Hannah, that's always helpful. But if you need something, if you have any worries, any questions, we are passing that information on to Hannah. So just let us know what y'all need.
All right. Well, I'll keep an eye on the chat if anything else pops up, but I'm going to hand it over to Lyle from HICPA to talk about a different project.
Yeah, hi you guys. Let me see if I can share.
You should be able to share.
Perfect.
Yeah, okay. All right. Just making sure.
So yeah, I am a business analyst on the Colorado Social Health Information Exchange, also called COSHI. This is a project that is kind of based out of the OHI office, the Office of eHealth Innovation, in partnership with Healthcare Policy and Financing. And so it's kind of a collaboration of a project. It's a 10-year project, and we're in year 2. So we're kind of at the infancy of the project and starting it. I am a licensed clinical social worker by trade, and I was a prison social worker for about 10 years. So I have a little bit of experience in the population, but obviously, every jail and corrections environment is different. So we're kind of here to see if there's some collaborations that make sense, through the COSHI and the type of like data partners that that we may be able to collaborate with and hopefully solve some problems throughout the system. Kind of like one of the ones that was brought up about billing and things like that, that may be something that we could look into, and sharing data and everything across different organizations. So, social determinants of health account for over half of a person's health outcomes. This is why there was an investment in the COSHI project. And obviously, like, social care delivery is fragmented and siloed, as, I think Ray was just kind of talking about that systems don't talk to each other, and sharing that data and information is very rare. So currently the burden of social care kind of relies on the person. And so, they may have to repeat their story that may be traumatic. And there's usually duplicative, referrals or processes or services in place because the left hand doesn't know what the right hand's doing. This kind of talks about the silos and all the different organizations that maybe an individual would be a part of, and trying to figure out a way to intersect all of those organizations. So we're looking at trying to do like a statewide unified architecture. So building a network with a focus on interoperability and data governance. We also just started about a month ago our regional proof of concepts. There were 4 agencies that got awarded some funding to kind of help show that this potential framework will work. And so 2 of those regions are in the rural area and 2 are in urban. And so we're looking at, continuing to work with them to see, what other agencies they can collaborate with. So some of the goals or the benefits for providers is that we're keeping the provider in their preferred system of record. It reduces administrative burden. It improves access to resources for the client. Again, kind of lessens the duplicative screening, reduces their time on their own care coordination, and hopefully improves access to care. The data and the information that we're maybe sharing between two entities, we're hoping to make it actionable. So something, that a care coordinator or somebody could, take action on, whether it be for housing or transportation or substance use, or, whatever the needs are of the client or the member. So COSHI is not a replacement for referrals, but it's to help close the loop referral platforms in exchanging the data. It's not a research tool. It's not, surveillance, and it's not a replacement to other health information technology solutions. It's not either a data warehouse. So we are not, saving this information in the COSHI. We are just we're the pipes basically that transmit the information from one entity to another. And so because of that, it can be customizable and flexible depending on, the technology maybe that the organization has, and, the resources and everything that the organization has. Again, it's a 10-year development, so we're still, at year 2, and trying to, figure out kind of the best ways to get the data flowing. So it's really building upon existing community networks, and it's engaging the community members in development. So the kind of 4 prioritized populations that we have are individuals that are experiencing disabilities, individuals that are experiencing homelessness, individuals with substance use disorder, and then individuals exiting incarceration. So that is kind of, our investment, in the jail communities, and trying to see if, there's a way that the COSHI system could help, individuals re-entering the community, and maybe sharing that data and that information. Currently, we're working with the RAIs, the Regional Accountable Entities, and we are sharing DOLA data, which is like housing voucher data, and then also the HMIS system, the Homelessness Management Information System, and we are in the midst of sharing that information with the RAIs currently. So that was kind of our first initial, priority, is to trying to see if maybe working with the jail entities, and then potentially sharing information with the RAIs, which may already exist. Jails, some of the jails may end up sharing that information already, but trying to see if there was any opportunities to help, in that sharing. Is what we were initially focused on, but we're obviously open to feedback because we are not the experts. So I think that's kind of the end of the kind of initial COSHI project and where we're at currently and where we're hoping to engage with other organizations, community-based organizations, but also, one of our prioritized populations is individuals re-entering into the communities. So if anybody would, I will share this slide deck maybe with Hannah or Becky, if you guys would like to, take a deeper dive into it or just share it even with folks back in your community, so that you can disseminate the information. So I thank you so much for your time. Yeah, I'll pass it back to maybe Becky. Or Hannah.
Yeah, I can take it. Thank you. Yeah, and if you'd like to send me your slide deck, I can send it out, or if anybody has any questions. This recording, as Rachel was asking a question about the recording as well. I'm going to be popping the recording onto the website, so anybody from the jails should be able to pop onto the website once it's on, and give me a couple of days, because I have to, for everybody, because I have to have it downloaded, then I have to submit it to our comms folks, and they are the ones that pop it on. So I'm kind of on their schedule to get it on. But yeah, they'll have access to this recording. And then if you have the slide deck, send it to me and I can send it to anybody that needs it. No problem. Awesome. Does anybody have any questions, concerns for either of our comments, for either of our presenters today? Awesome. What about anything for our JBBS team? We have Danielle here now, so thank you, Danielle, for joining. So anything for myself, Alex, or Danielle at this point? Commander's thinking. Well, if you do have anything, as always, please feel free to reach out. You can reach us on email. You can reach me. Thanks, Commander. You can reach me with my cell phone as well. So let us know if you need anything. If you would like to pass on any information to Hannah, also let me do. Thank you, Ray. Appreciate you. But I'm going to give you a whole 5 minutes. So go change the world with the 5 minutes that I'm going to give you back. So thank you, everybody, for your time. Appreciate you. And we will see you next month. Thanks, everybody.
Thank you.